Welcome back. Let's Get Physical Therapy is an educational podcast brought to you by MedStar Health and hosted by me, physical therapist Becca Schumer. I will be sharing the mic with tons of healthcare professionals with the goal of educating and inspiring fellow PTs and future PTs. We hope you find this both informative and inspirational, ultimately optimizing how we treat our patients and grow as professionals. Please enjoy today's episode. We have Dr. Steve Epstein. He's a professor and chair of the Department of Psychiatry of the Georgetown University School of Medicine. He's chief of service of the Department of Psychiatry of MedStar Georgetown University Hospital and is the physician executive director for behavioral health for MedStar Health. He received a Bachelor of Arts degree from Yale College and graduated from the University of Pennsylvania School of Medicine. After completing a residency in psychiatry at Tufts New England Medical Center, he was a fellow in consultation liaison psychiatry at MedStar Georgetown University Hospital and Inova Fairfax Hospital. In 2016, Dr. Epstein served as president of the Academy of Psychosomatic Medicine. He recently ended his term as vice chair of the Consultation Liaison Psychiatry Committee of the American Board of Psychiatry and Neurology. In July of 2015, he was appointed to a 6-year term as a member of the Psychiatry Review Committee for the Accreditation Council for Graduate Medical Education. For the past 7 years, he has been a visiting professor at Moi Teaching and Referral Hospital in Kenya. So we are excited to continue on with our conversations regarding mental health during May, which is Mental Health Awareness Month. So let's dive in. Hi, Dr. Epstein. How's it going?
Very good. How are you?
I'm doing well. I'm so happy that you are joining us for May, which is Mental Health Awareness Month. I really appreciate you taking some time to talk about this topic with us.
My pleasure.
Sweet. So we like to start asking our guests how you got into the field that you're practicing in. How did you become a psychiatrist?
So all the way back in late high school, I knew I was really interested in how people feel and think in the human mind. So I was a psychology major in college and then thought I would just use that to help me be a better doctor and that I would be in regular internal medicine doctor, but then my first psychiatry rotation, I realized I love this and this is where I want to go. And then the rest was a straight psychiatry path.
What population were you working with at the time that drew you in?
That is an interesting story. Many different kinds of mental health problems, but actually at that time, this was the heyday of diagnosis of multiple personality disorder, which is not even called that anymore. It's dissociative identity disorder. And there were people there who had many different, what were called personalities then. And really how we would think about it now is very traumatized people who really needed a lot of help. And I got to see them not well, but also getting the benefit of good mental health care.
What population are you working with, or what's your job look like now?
So I spend lots of time on email and doing administrative things, but I do still teach the residents and students, and I have a specialty area within psychiatry, it's called consultation liaison psychiatry. It means consulting for people who have serious medical problems, who also have mental health concerns. So seeing people in the hospital who are very depressed or very confused, or they need a psychiatrist to figure out if they are really thinking clearly enough to make medical decisions. I do that. That's been my specialty area in psychiatry for my whole career.
Very interesting. Okay. And why is this topic so important? We're spending a whole month bringing awareness to mental health, which I'm really excited about. But what does it mean to you?
Well, there's the bad news and the good news. The bad news is it's so important because there's so many people with mental health problems, and we're seeing it particularly, as you know, in adolescents and young adults, and it's really a problem. The good news is that awareness is increasing. Stigma is clearly decreasing. So people who even 10, 20 years ago would be very reluctant to go seek mental health help, to talk to their friends and families about mental health problems, they are now seeking help and talking openly about it. So that is what, the silver lining in all of this.
When someone's struggling, what's a good first step for them to take if they're noticing either they're starting to isolate or their mood is changing or their behaviors are changing? Where's a good place for someone to start when they're seeing these changes starting to occur? Or if you see a friend starting to change, how can we help them?
I think that the first step is to figure out if it's a brief, transient, mild problem that lots of people go through. And if you're having a bad day or a bad couple of hours, you can do some things to get out of it, and whether it's exercising or getting outside or calling a friend. But the question then that we should ask ourselves or ask about our friend is, well, what if it's worse than that? And I think you could start with asking, well, am I depressed or am I anxious? And you can, go online and do screening tests. They're all available. If you don't want to do a screening test, I think that the best way to think about it is, well, like I said, everybody has a bad couple of hours or a bad day here and there. But if you are finding that even though things are going pretty good for a few weeks or months, and even on good days, you are feeling really nervous or really down, or you're thinking about not living anymore. When it gets to be that serious, then you really want to get some professional mental health help.
I wanted to go back for a second because you're talking about destigmatizing mental health issues and people, I'm quoting, coming out on social media, just with their friends and family. Why is this so helpful? And if someone is thinking about coming out with their own story, do you have any recommendations for someone to do that, to not do that, depending on where they are in their journey of their mental health?
Why is that important? Well, if it depends. I mean, sometimes it's not good if it's very negative, and we don't. That's not helpful. But most of these stories, as you know, are very positive, and what they're saying is, I had a mental health problem, whether it's substances or alcohol or depression or eating disorder, and I want you to know that even someone as seemingly rich and famous or popular as I am, I too have had mental health problems, and I got help, and now I feel better. Those stories are very helpful. Unfortunately, there's some very upsetting things on social media, people sharing, violent events or thoughts. That's or how to lose weight. Those are toxic. And so, again, there's some positives, but sometimes social media is not helping people with mental health problems at all.
With mental health, what are the trends right now? What are the more common conditions or disorders that we're seeing?
The most common problems are depression, anxiety, and substance use problems. They're less common are some very severe problems like schizophrenia and bipolar disorder or manic depression, severe debilitating depression, and unfortunately those are not rare. So the very severe problems where people cannot function while they're in the middle of an episode, that's up to 5% of the population. The milder, more common ones, or I shouldn't say mild, but the not necessarily completely debilitating, more common problems, 20 to 30% of the population at least. So these are just not rare at all.
Again, this podcast is mostly for PTs, PT students, but hopefully other people will be listening too. When we're treating patients, it's obviously a very difficult, challenging time in their life. And I'm guessing that some of these conditions or disorders can manifest or get kind of worsen in these episodes. So what are some ways that physical therapists or healthcare providers can be aware of, say, a spike or a relapse or something, and how can we help them?
Mm-hmm.
And stay within our scope of practice?
Exactly right. That's a great question. If you're working with someone over a period of time, it's a lot easier than, if you see them once and they don't come back. And I would say, if you're seeing someone once and they don't come back, you hope that they're getting help from somewhere else. But when you see someone more than once, you get to know them, and you say, as you are trained to ask open-ended questions. So you don't just go start right up with a therapy session. You can say, how's the last week been, or how are you feeling? And it doesn't just mean how is your knee. So if you say, how are you feeling, and the person says, I don't know, I don't know, even something like that, listen and think, I wonder if something else is up. I wonder if they mean something like that. And you just say, well, what do you mean? And just open-ended question. Take some time, but just like you would do with a friend. Like if the person just doesn't sound quite right, and then it can go down a path. And if they say, I've been feeling down, you say, oh, tell me a little bit about it if you feel comfortable. And then if it becomes something where they say, no, I'm okay, but I'm just under stress with my partner or with school or work or whatever, you say, okay, well, okay, I hope you're feeling better. And if they go ahead with the session and everything is fine, you let it go. On the other hand, if they start saying, yeah, it's been really bad, then a couple things. One is you should not be doing clinical assessments for depression and for suicide. That's, like you said, not within the scope of practice, but you should be equipped with how to refer. An easy way to start for you all would be, and for the students would be, to know something like this. Well, is this something you've talked to your primary care doctor about? Or is this something that where you would like to have some list of resources for where there are therapists, and your supervisors can provide you with that. There's a lot of mental health resources in DC and Baltimore, and through MedStar Health and other places. But I think what's important about your question is that what I wouldn't want the students and the therapists to think is the following. Well, since I can't do anything to help and I'm not a trained mental health professional, I better not even ask, how are you? No. Ask, how are you? What's up? And then if it gets to be complicated or serious, you refer.
As a student, sometimes there's just tunnel vision to treat the injury that's in front of you. The script says PT eval and treat for right knee pain, and they're just right knee, that's what I'm seeing. And I think it's important to stress the importance of listening to our patients. If our patients are going through all these things, their knee pain might be a manifestation of that stress that they're going through too. So not minimizing all the other things that are going on in their life and how that can affect the thing that they're coming in for even, right?
That's right. Well, and our medical system has become fragmented. So people are seeing a lot of specialists, and it's easy to have that tunnel vision because that's why they're there to see you. They're there to help. You're there to help them to recover from their knee surgery or from their sprain or whatever it is. Just to make the students feel better. All of us, all specialties, including psychiatrists, have tunnel vision sometimes. So on a bit of a tangent, but I'll share with you, we have to make sure that psychiatrists don't only focus on depression. So psychiatrists are trained to say, well, how are you feeling? If a person says, I'm short of breath when I'm walking upstairs, we have to know, well, wait a second, tell me more about that. That could be cardiac or pulmonary, not depression, right? Because depression doesn't cause shortness of breath. So all of us need to step out of our lane, as you said, just for a little bit and say, how have you been? And I think it's a good teaching point for all your students and the students, honestly, in every specialty.
In med school, are they teaching students about psychology for themselves, how to take care of ourselves versus not just for addressing patients?
There's well-being programs.
Okay.
And so again, I guess one of my themes is the good news and bad news of what's happening with mental health now in the U.S. And the bad news is there's a lot of provider burnout in every specialty, including yours. It's probably been most highlighted with nurses during the pandemic, but also every specialty. And that's the bad news. The good news is that it's really helped to shine a spotlight on well-being programs and programs to prevent burnout and teaching self-awareness in students so they know when they're getting stressed. And why is that important? Well, because it's important for everyone to take care of their well-being, but it's also it's even more important for healthcare professionals, because if you're not taking care of yourself, then you're not going to be as effective a practitioner.
How are some ways that we can help ourselves in that?
There are stress scales that you can take, like I mentioned before. There's also stress thermometers you can Google this, it's out on the internet, where you can say, how I'm burned out every day and I'm thinking of quitting is really high versus the other end of the spectrum. I am not stressed at the end of the day. I have a good evening when I come home from work, and I love my job. Two ends of the spectrum. And so you want to take your own pulse. Some people have said, take your own emotional pulse. How am I doing? And what you want to check on, and this is really every day. Like, how do I feel? How's my breathing? Are my muscles tense? And those are signs, physical signs, but also emotional signs like, am I snipping at other people? Am I more irritable? So that's it. You want to really pay attention to that. And we'll talk later about strategies to reduce that. But the first step is self-awareness. And I can tell you that one of the biggest problems that I see in healthcare professionals who are stressed and burnt out and thinking of quitting, and there's a lot, is just thinking this: well, I don't have time to check on myself. And it doesn't matter anyway, because I don't have any time during the day. So I'm going to power through it, see all my clients, patients, get all my notes done so I can get home. And then we say, well, you're going to power through it, and then you're going to be completely burnt out at the end of the day and stressed and not sleep or maybe drink too much. Why don't you take, and I'm getting to strategies, why don't you take a 15-minute break in the morning and in the afternoon and just meditate or listen to music or call your best friend from Chicago? These things, they lengthen your day, but you feel so much more fulfilled and so much less kind of cranky and irritable. And nobody wants that. Your patients don't want you to be irritable, and your colleagues don't want you to be. So it's really taking your own emotional pulse and then taking those breaks for well-being every day, not just waiting until you're stressed at the end of the day.
For someone that's a little more resistant to those strategies, like meditation, I don't have time to sit there in a dark room and count to 10. How can we encourage someone to take that first step to try something and try a strategy that maybe they don't think will be effective, but actually really will? How do we encourage them to just try it?
So when you are telling me that you're feeling stressed during the day, you recognize that you're stressed, right? So I want you to role play with me for a minute, okay? Do you recognize? Do you want to feel better during the day, or is it just doesn't bother you?
It bothers me a little bit.
Okay, so if it bothers you a little bit and you don't want to do anything about it, that's completely up to you. Now, that's assuming, by the way, I'll step out of the role play for a minute, that it isn't like their supervisor is complaining that they're okay. But if you do want to work on it, would you like to talk about some options?
I mean, I've tried 10 things before, and none of them have worked. So
okay, so if 10 haven't worked, we can spend some time on those 10, right? So we can review them if you'd like, or I can suggest a couple of others. But that's up to you. So what you're doing there is you're empowering, and I'm stepping back into our podcast here. You're not saying to somebody, let me give you a lecture, right? Now, your story, the way you are role playing now, is actually, thankfully, not that common. So what is common is your first comment, which is, I don't want any of that blank stuff. Like, I don't want that meditation stuff. Or, I know you're telling me to exercise every morning, but I don't have time. So what ends up happening is very few people, this is the good news, very few people say, I've tried 10 different ways for stress reduction, and none of them work. In that situation, I would try to find 2 others, or say maybe we can tweak some of them. So maybe the way you tried option 4, which was taking a walk, didn't work. So what if you did yoga, something like that?
Yeah.
But most people, what it is, thankfully, is there are a couple of things that work, but I don't know that I have time to do that. Or I've tried 2 things and they didn't work, and then we have a menu of 5 other things. So there's all kinds of well-being resources available anywhere on the internet, and the MedStar Center for Wellbeing has all that there. All these self-care resources. So that's how you can have that conversation with somebody.
I think sometimes for me, like, I'm all in 100%. So if I can't, I'm aware of it, but if I can't do something 100%, then why do it? Like, why do half of it? So
Right.
Reframing that and saying, I have 5 minutes. It might not be the 30 that I want to do, but at least I have 5 minutes to dedicate to taking care of myself.
Well, you all are you're much better exercise experts than I am. Okay. But I got to tell you, it's gone in the last 10 or 15 years from how to get the benefit from what benefit is there from a 30-minute workout down to probably 20 and then 14 and then 11 and it's now 8. And then I've seen the high intensity, 4 minutes of something, right? So what we say to people is, maybe you can't do a half an hour, but what about intensive something for 10 minutes? I tell people this story all the time, but President Obama used to exercise every morning. I mean, then I would say if the president of the United States, who's somewhat busy, then you can build it in too. So that's exactly right. I mean, perfect is the enemy of the good. And yes, if you're used to saying a workout isn't a workout unless I do X number of calories or X number of minutes at 100 and whatever percent of my, aerobic target, no, anything helps. And a lot of the new data on steps, for example, is getting a lot more nuanced. So it's saying, there's not a magic 10,000. It's not 10,000 or 9,500 is no good for you.
Right.
Right. So whatever you can do is really going to help, even if it helps, like you say, even if it helps 50% of stress reduction, not 100%.
Mm-hmm. Definitely. I'm going to take a left turn here and go into more of the substance abuse and the opioid epidemic. Mm-hmm. Tell us a little bit about what's going on with that and why we need to be aware of this.
Yeah, this is bad. There's a long story to the opioid epidemic. And I am happy to talk about whatever you would like. So just the snapshot now is that not only are people debilitated from addiction, but with the synthetics, particularly fentanyl, the death rates are very high. So in the old days, it would be bad to be addicted to pills or heroin. And there are all kinds of health problems from that. I mean, it affects your moods, it affects your ability to function, you can get infections. There's stigma associated with it. Families could kick you out. It was not good. But it was relatively uncommon compared to now to use a drug and then be dead instantly. And what's happened because the potency of the fentanyl is so high and other drugs and other analogs, that the opioid death rate is extremely high. And that is a real crisis now.
And that's the number one killer of mental health illnesses, correct? And then I think second is eating disorders, but is that right, that it's number one?
You know what? I'm going to have to look at, it depends. First of all, it depends on the age groups.
Gotcha.
And the eating disorder, just to reassure some people, just because you brought up eating disorders, the death rate, the mortality from eating disorders is really for very severe anorexia nervosa. So I am not saying that if you have, a binge eating problem or bulimia, that's not a problem, but the death rates for them are very, very low. But remember, there's suicide too. So suicide is very high. What makes it complicated is there are people who try to end their life because of depression, but also with substance use. And one of the problems, since you brought up drug use, is if you are overusing drugs intentionally, meaning you know that there's a lot of fentanyl in something, is that suicide? Is that, well, I didn't want to kill myself, but I didn't care if I overdose? So there is an overlap between use of extremely high potency drugs and the possibility of self-harm. So anyway, but it is high.
We talked beforehand about how to differentiate between someone who truly has an addiction versus someone who is going through a course of pain and needing to be on them for a little while longer because of that. How do we decipher, where's that line crossed?
So if someone let's say they've had surgery and they say, I still have knee pain, the first step would be to, talk to the surgeon who is doing the follow-up visit and say, well, when you've done surgery like this, shoulder surgery or knee surgery, how many days do you typically give opiates for people who, post-op? And if they're saying, and this, that one of the things to address the opioid epidemic is is physicians have been trained in not necessarily just giving, a month's supply, or refills, and like in the old days. So if, for example, someone has knee surgery and the surgeon will say to you, we're giving some oxycodone for 3 days and then we just switch to non-opiates. But then the person is coming back days and days and days and weeks after this and saying, well, this is terrible and I'm having severe pain and I had to go to another doctor to get opiates, and you don't understand. That's a red flag. The second thing is that's hard for you all to get, but if there is a history of addiction, so for example, if you look at the chart and someone has had, office visits or a hospital admission, and addiction is a big issue, they are more at risk for now having a recurrence. So I would look at that. And so, this doesn't mean that everybody who is saying, no, I've had persistent pain for weeks after my knee surgery is, quote, drug seeking, because it is possible there are other things happening. For example, maybe there was a problem after surgery. So I don't mean it that way. But these are more kind of red flags or warning signs to keep your eyes open that there could be addiction.
Yeah, personally, I've had a lot of surgeries over the years, and 20 years ago, I would get even like 60 pills. And now I've had a bunch of surgeries in the last few years, and it's so interesting because depending on the complexity of the surgery is dependent on how many they give,
yes.
And it's far less than it used to be. So
yes.
From a big procedure, I might get a month's supply, and then for like a removal of hardware, maybe a couple of days supply.
That's
so
right. Yeah.
Personally, I've definitely seen the transition of that given the crisis that is occurring. If someone has been taking a lot of medications, we're not doing our due diligence to communicate with the doctor, we're not talking to our patient enough. What's the trajectory going to look like for that patient if we don't step in or if we don't bring awareness to this issue that's happening?
Mm-hmm. Yeah, so it depends. I mean, some people will recognize it themselves. Oh, I've been taking opiates for a few months. What's going on with me? Sometimes they've had problems before and they say, I don't want this to happen again. Sometimes their family will say, what's going on with you? You've changed, or how come you keep taking those pills? So sometimes it just goes away. The problem, though, is that these medications are highly addicting. Now, what does that mean? Well, addicting doesn't just mean I keep taking it. What it means is that the chemical properties, the pharmacologic properties of the medications hijack the reward centers of your brain, these dopamine reward centers, not to oversimplify, it's not all dopamine, but what they do is they make you want to take the drug. And they make you crave the drug, and they also make you feel miserable if you don't get it. And so these reward systems get out of whack. And so that's why people might even think, I know I should be getting off of these, but I can't. Or it feels so bad when I try. I've tried to stop, or I've tried to taper. It feels so bad I can't do it. And some people say it feels great and I'm happy to be, using again. But, most people, it's a misery cycle, not just a euphoria cycle. And that's where you really want to say, can we get you some help? You can get through this. And if people say, no, I can't, I'm just, I've been to rehab 3 times before, you say, no, if this time is going to work. I mean, this time, we hope this time could work. It works for a lot of people. So you never give up. You never, ever say, oh my gosh, it's hopeless, or these people with addiction, they're just weak, or something. No. We just keep intervening until people get better. And sadly, some don't, but many, many, many do get better.
As you're talking, I'm thinking about patient A, patient B. Patient A can take it for 3 days and then they hate it, they want to get off of it. And patient B keeps taking it. What is the difference? Why do some people, is it genetic? Like, is there a genetic piece to it? Is something clicked on, like once they get going on it? Why is it such a drastic difference between patient A and patient B?
Yeah, nobody knows. Maybe you should do that research as your second career. That would be wonderful. If you were to do some sort of biologic and psychological interview testing of a 10-year-old to try to predict, who might be in which of those categories. We don't know. It's probably, and there is a genetic component, or genetic, I should say, genetic contribution to addiction, but we just don't know yet. What we do know is what I had mentioned earlier, which is if you have a 35-year-old and you say, well, why is this person, getting addicted again, and another person isn't? That the people who have had some problems with addiction in the past, their reward systems may be off. And so these are people who will say, I have, in many, many stories of this, where I have had addiction to heroin over the years. When I had my knee surgery, I told the doctors not to give me medicine, but they did anyway. And then all of a sudden, after 4 days, I felt amazing again. And I knew it wasn't great for me, but here we go again. That, by the way, I don't know if you've seen anybody with this. I'm sure you've seen, if you haven't, your colleagues have, where people will say, look, I know I'm having this surgery, but I cannot have any opiates. Don't even give me 1 day. And then the surgeon might say, fine. The surgeon might say, you don't understand, it's extensive shoulder repair. This is going to be agonizing. And maybe you put in a pump and then you take it out, no pills, right? So there's, again, back to the kind of our stigma point earlier, there's increasing awareness of addiction and what it can do to people. And that can have a very positive side where the patients themselves can say, please don't give me drugs. That because I know the way my brain works, whether it's genetics or what it is with my reward system, but I am prone to getting, addiction again. Please help me. And the doctors are getting trained very well now, mostly very well, to say, yes, we're happy to help you.
This may be a really dumb question, but it popped in my head as you're
talking. I don't think it's going to be a dumb question. I'm just predicting.
Addiction, if we have an addiction to something else, say like shopping or gambling, is there any carryover? Is that just a predisposition to have this addiction gene? I'm quoting, I don't know.
Yeah.
And then more prone to developing an addiction in something else, or are they kind of siloed? Like you're addicted to that, you're not going to be addicted to that.
Yeah. I don't know enough to comment on that. What I can tell you, though, is that some people have more than one, quote, addiction. And so what I thought you were going to ask me, which is equally difficult, is like, well, is gambling addiction like an addiction, just like, heroin? How about, quote, internet addiction? And one of the answers is yeah, because it hijacks these reward systems. You get a rush when you're doing it. You get a crash when you're not doing it. And yes, there are many people who have more than one, whether it's, gambling and drinking at the same time. I can't give you data, but yes, it's a great question.
As we start to wrap up, any other things that you want to bring to our attention about the importance of this month, and not just this month, but being aware of it every day?
No, I think you've highlighted a lot of really important areas. One of the themes is that we're all here to improve the healthcare, of our patients and consumers. And you've really highlighted that we should be looking at the whole patient. And if you hear warning signs, I'll give you another example. What if you've been working in physical therapy with someone for a while and they're supposed to have 5 more sessions, they don't show up? And that's just not like them. Reach out, say, hey, how are you? So just think of the whole person, and the mind and body are one, like you've said. So I think that's an important theme for all of us in healthcare.
We get into this field because you like to help people, and sometimes all the other factors come into play and override that, like productivity. But at the core of it, we're all human, and just taking care of the whole human and not neglecting why we're doing what we're doing.
Exactly.
We'd like to end every episode with a favorite quote. So I would love to hear your favorite quote that moves you, drives you, inspires you. Okay,
so I promised to your listeners that I didn't ask you to cue me up for my favorite quote, but you don't know it, but you just did. So this quote, which is complicated, so I'm going to read it twice, directly addresses your question, which is, if you are really, really busy, you've got lots of people in the waiting room, and you have notes to write, is it okay to say, you know what, I don't feel warm and fuzzy towards this next person, and I don't want to ask all the questions because they told me last time they were kind of depressed, and I just don't want to because it's going to make my day longer, but I'm going to do it anyway. So there's a book about empathy. And the book has one of my favorite quotes in there. And the quote is about, if you don't perfectly feel empathetic, is it still okay? Is it a form of empathy to say, I'm going to make an effort to be kind and loving and human today, even if I've got all kinds of family problems myself at home, or even if it's late at night? So the quote is, and I'll read it twice because it's complicated. This confession of effort chafes against the notion that empathy should always arise unbidden, that genuine means the same thing as unwilled, that intentionality is the enemy of love. So I'll read it one more time and explain. This confession of effort chafes against the notion that empathy should always arise unbidden, that genuine means the same thing as unwilled, that intentionality is the enemy of love. In other words, if you pause and say, I am going to make an effort, even though I don't feel emotionally like it, to be a kind and caring person with my patients, that is love. So I love that quote. And it's on my phone all the time, not just for you.
I love it. Thank you so much for sharing that with us. Dr. Epstein, where can people find you if they want to get in contact with you?
So MedStar email, Georgetown email, I'm available. So
Okay, I'll put it in the show notes.
perfect.
Awesome. Thank you so much for joining us today. This conversation has been amazing, and I really appreciate you taking the time to spend with us today.
Thank you for highlighting this topic and for having me.
Thanks for listening to the Let's Get Physical Therapy podcast. Be sure to subscribe to our podcast and follow us on Instagram at MedStar Health PT. If you've enjoyed today's episode, please give us a 5-star rating and leave a review so we can reach more listeners just like you. As always, we appreciate your time and hope you join us for our next episode.